Hi, everyone, and welcome to this Friday afternoon's webinar with DeWitt Wilkerson. I have been looking forward to this great afternoon for ages, and I hope we all enjoy ourselves. My name is Jette Holbrook, and I'm a retired chair of BSOS, and I'm delighted to welcome you all here. Do sign yourselves in so we can see who you all are and where you're from in the chat box, if you don't mind. I'm very excited about this webinar. As I said, I have had my signed copy of Witt's book, The Shift, for ages, and I have also read it. And now I look forward to hearing him in person inspire me with his thoughts and his insights. And thankfully, we have the opportunity of listening more to Witt next year, as he will say in one of his slides. The 29th and the 30th of September next year will be in London, we presume, where he will have a full 2 days with us. So do get that in your diaries. And for a few of you who haven't managed to get your BSOS membership up to speed, if you could do that with the help of Patricia, that'd be really helpful. Thank you. Witt is, in my opinion, the nicest person and a good friend. He is a scholar and an educator, and he has been, or even is, the president of more societies than I can ever list. He is or has been involved with the Dawson Academy, the Pank Institute, and is an adjunct professor of the University of Florida. He was also the partner of Pete Dawson in Florida, and he worked in the same building as the deservedly famous and talented DMJ surgeon, Mark Piper. So Witt is eminently qualified in this field and has chosen to invest lots of time and effort to know as much as possible. So Witt, thank you for sharing all that with us this afternoon, or a fraction of it anyway, and the floor is yours.
Oh, thank you so much, Jette. It's a pleasure to be with you and with BSOS and share with you some of the exciting things that we're learning. Patricia, if I could get, if you can enable me to share my screen, I'll go ahead and do that. But and thank you for taking time on your Friday afternoon to, there we go, to be with us. I'm actually 4 hours behind you in Florida. And so it's just before, just a little afternoon, excuse me. Today, we're going to talk about integrative dental medicine. And I'll explain that in great detail, what we mean. But this is intended to serve as an introduction to what I believe is going to be the next great frontier in dentistry. And I'll try to demonstrate that as we talk through together. But as clinicians who are concerned about occlusion, who are concerned about malocclusion and orthodontics and restorative dentistry, which is my background, I don't think there's a more important topic for us to discuss as far as our goal and purpose in becoming problem solvers and those that create beautiful smiles that are also stable and healthy in a person who is stable and healthy as well. And so let's jump right into our thoughts here. I want to, let's see, there we go. Jette introduced me very beautifully. I thank you, Jette, but I have been around a long time. Most recently in the last year, we've launched a group called the Integrative Dental Medicine Scholar Society, or IDM Scholar Society. And that really is an extension of what we're going to talk about today. And the book I wrote, which is called The Shift, which really means the paradigm shift in dentistry, from us in dentistry being tooth carpenters to being true oral physicians of the masticatory system, who are looking at the whole person and thinking about all aspects of not only their oral, but systemic health as well. And so I've been very blessed to have a background in occlusion, TMD, restorative dentistry, aesthetics, and teaching with Dr. Dawson for over 30 years. We've had over 40,000 dentists come to St. Petersburg for training under Pete and our group. And so we understand the challenges of dentistry. We understand the challenges that we all have in our practices. And one of the biggest challenges is being able to predictably solve problems. And so that's always been our quest, is how to solve problems. And I believe that the things we're going to talk about today are several pieces of the puzzle that we haven't had until more recently that really make a huge difference in our impact in the health of our patients' lives. And so I look forward to sharing with you. I want to tell you that I have a British background. When I finished high school, before going to university, I spent a year at Cape and Ray Bible School, which is in Carnforth in North Lancashire. And so I very much loved being involved in the culture of the UK and traveling on the weekends on trains and spending weekends in London and Glasgow and Edinburgh and Liverpool and all around the different areas. And so I have a great love for Great Britain, and actually my grandmother was born in the UK, and so I feel very, very closely attached to it. I love the people of Great Britain. And from that time I spent at Cape and Ray, I think this really became an example of the philosophy that I learned there, and that is success is knowing your purpose in life and then growing to reach your maximum potential so that you can also sow seeds that benefit other people. And I don't know of a better profession on the planet to do that than through dentistry. And so I loved my career, which has spanned now 40 years, and every day of it has been a joy. But also a big part of success is family, isn't it? This is my wife, Pat, and our two grandchildren, Carolina and Danny. And we love spending every minute we can with them. And I've been blessed to be married to Pat for 42 years. And she's the joy of my life and just such an inspiration to all who know her. And so that has been a very successful part of our lives, but also professionally. Let's think about what we have lived through, some of us that have been around a while, the different frontiers that we've seen in dentistry that have happened in such a short time. Because if you think back to the 1950s, well, this was pretty much dentistry, wasn't it? Partials and dentures were mostly what was done in dentistry. And I remember in the early 1980s when I started, we were making a lot of dentures and a lot of partial dentures. And that was a very commonplace thing. We've seen so many things, though, happen, haven't we, in the last 40, 50 years. And these great ages of occlusion and restorative and perio and TMJ therapy and cosmetic aesthetic revolution. And now the digital age, which is just mind-blowing, isn't it? I've been fortunate to be on the front lines because of working beside a pioneer in each one of those subjects, Dr. Pete Dawson. And these are some of his textbooks that he's written, and those have been translated into many languages and used all over the world. And so the question that has always arisen in our practice through the influence of Dr. Dawson is this: is there a better way? That's the key question to his great influence, was always asking, if there's a better way, then we should learn it. Is there a better way? Then let's go find out who is doing something better, learn from them, and then we will come back to the office and implement those new systems or techniques. And that has been really a revolutionary concept that he was very much responsible for. In 2019, a book was written about Dr. Dawson called A Better Way, and it explains his philosophy of life and of dentistry. And I really want to recommend that to you as a great read, because it's so inspirational as you look forward into the future and think about the potential that is unlimited in your life and in your practice. I think this book would really be of tremendous benefit. So today we're asking, so where do we go from here? What's next? What's the next great frontier to explore? And I want to introduce you to how I began thinking about a specific next frontier, and that was an invitation that I received in 2012 to attend the second annual meeting of a brand new academy in the US called the American Academy for Oral Systemic Health, or AOSH is how it's referred to. The meeting in 2012 was held at the Cleveland Clinic, very famous medical center in the United States that is well renowned, and patients come from all over the world to be treated there. Here you see Michael Roizen, who is the medical director of the Cleveland Clinic Wellness Institute. And he was the keynote speaker at this meeting, which was primarily dentists and hygienists back in 2012. And we heard phenomenal speakers like Dr. Caldwell Esselstyn. Dr. Esselstyn had been the chairman of surgery at the Cleveland Clinic, one of the most highly regarded positions in all of medicine in the US. And Dr. Roizen was the chief of anesthesiology also at the Cleveland Clinic. And they worked together every day in the operating room. One day, the two of them walked into the Cleveland Clinic and said, "We quit. We don't want to do this anymore. We don't want to put people to sleep, open up their chests, and replace and graft in new veins around their heart because their arteries are completely obliterated by atherosclerosis to the point that it's completely destroyed their health. We want to understand the root cause behind why we're doing surgery, and that would be, why do people develop atherosclerosis? Because if we can understand the why or the cause and effect there, and we can treat that original causation factor, then we won't be in the OR doing open heart surgery and doing quadruple bypass surgery. And so they both committed the rest of their careers to pursuing an understanding of the cause of the chronic diseases that we see throughout the United States and Western world, most especially cardiovascular disease. And so we heard speaker after speaker talking about these things and describing their research and their work there and how they're addressing diabetes and how they're addressing sleep issues that are related to things like sleep apnea, and how they're addressing systemic inflammation, and how they're reversing aging and just doing and performing miraculous things. The key thing that I heard there that weekend was this: you have to look at the whole person. You don't just look at the symptom and diagnose that and treat the symptom. You have to look at the cause behind those symptoms. And this is what is known as integrative medicine. At the end of that weekend, Dr. Roizen challenged all of us that were in the audience, dentists and hygienists, and he said, you know, we have a healthcare crisis that's destroying our nation, and I'm sure the nation of the UK as well. And he said, and we have two choices. We can either ration healthcare and put a limit on your access to healthcare and the benefits that you receive through healthcare, and we all see that happening, don't we? Or he said, on the other hand, we can become rational. And by becoming rational, he said, I mean that we each take personal responsibility for our own health. We're not waiting for our doctor to make us well. We're taking control of that ourselves through our lifestyle choices. And what he pointed out was the fact that we now are seeing that, yes, genetic predisposition and heredity is important for our lifestyle, our lifespan to some degree, but those genetic markers have to be stimulated or turned on. And often our lifestyle factors are those switches that turn on these signs and symptoms of disease. And so the challenge that Dr. Roizen gave us was this: I believe that dentists should be on the front lines fighting the health crisis that is destroying our nation. When he said that, I knew that was my calling. I understood that this was the next frontier. This was the challenge that we faced. This was the area that we should begin to study and dig in and research to understand, where does dentistry fit in to the bigger picture of complete health? And so I began going to meetings all over the United States, where the conference would be for physicians on Alzheimer's, physicians on diabetes, physicians studying cardiovascular disease, heart attacks, and strokes. And one dentist would be there. That would be me. And I would be thinking the whole time, where do we fit in? What's our role? Do we have a role? What would be appropriate? What would be stepping over the line? You know, what can we do? Can we be primary care providers for our patients who, as we know, the initial portal into the body is the oral cavity. And so could we be sort of the gatekeepers of that portal in which pass so many things, and so many things happen that relate to complete body health, and in fact can reflect problems that are coming from other parts of the body. And so that's been the journey. And from that journey, we've coined a term which we're calling integrative dental medicine, just piggybacking on our colleagues in medicine and slipping dentistry in there to create a field of interest and study that would be integrative dental medicine, or IDM. And so simultaneously, there's been some movement, some shift in medicine as well among some of our colleagues, not a very high percentage, but here's an article that was part of stimulating a movement among colleagues in the United States that practice medicine to want to look more completely at the patients. What we've learned is in the United States, most physicians spend about 15 minutes every 2 hours with their patients, 15 minutes every 2 hours, just enough to get a chief complaint, to do a test and write a prescription, and then send them on their way. And so is that really good enough? Is that the standard of care we want to have in the wealthiest nations in the world in which we both live? So in this article written in 2006 in the American Journal of Public Health, Dr. Breslow states it very well when he says, we've had three eras, or there are three potential eras of medicine. The first era is what we'll call the infectious disease model era. And that's the era when antibiotics and vaccines were developed, like Jonas Salk in the polio vaccine in 1957. Life-saving discoveries, very important discoveries, but limited as far as looking at the whole person and other factors that may be affecting their health. So in the second era, new things were developed. We call this the reactive model, where there were life-saving procedures developed, even to the point of developing the ability to replace organs that are failing. So you remember Christian Barnard in South Africa doing the first heart transplant in 1967. Life-saving procedures. Now we can replace every organ in the body with a new one, and it's critically important. But does it really address the why that they need to have that organ replaced? And so the third era is the challenge one. And this is what I want to challenge us in dentistry to consider. And this is what's called the root cause model. And the root cause model, the principle is you ask why until you can't ask why anymore. So I mentioned Dr. Esselstyn at the Cleveland Clinic, and the question he and Dr. Roizen were asking was, why does cardiovascular disease develop? Why do we develop plaque in our arteries? And that turns into atherosclerosis that can be life challenging and even cause a heart attack or a stroke that's fatal. And so Dr. Roizen and Dr. Esselstyn really dug into the research, and what they discovered was very interesting, that cardiovascular heart disease is primarily a disease of diet and nutrition, or poor diet and nutrition. And Dr. Esselstyn has proven through working with hundreds of patients and doing angiograms of their arteries that they can actually reopen arteries through a very strict, basically plant-based diet. And it is quite remarkable to hear him lecture and to show case studies and to read his books about these things. And he will say in front of a group of cardiologists, cardiovascular disease is a paper tiger. It's completely controlled by what you eat, and I can prove it. That's astonishing information. But that's from asking why. Another wonderful researcher was asking the question about type 2 diabetes. Why does that exist? This terrible malady that's been compared to having shards of glass scraping the walls of your arteries all day and night. Almost nothing worse could be going on chronically in your body than having uncontrolled diabetes. Well, Dr. Joel Furman researched this for over 20 years with a large population of patients and wrote this book called The End of Diabetes, in which he demonstrated through his research and that of many others, and verified through a number of studies, and including a large study at the Cleveland Clinic, that type 2 diabetes can be reversed 90% of the time without taking pills or prescriptions through lifestyle changes. 90% of type 2 diabetics can reverse and lower their blood sugar levels and insulin resistance to a normal level without medications through lifestyle changes. Well, this is revolutionary information. This is dramatic new insights and potentials for solving problems. The reason is because they've gone to the root of the problem and understood that. And when they can change the root of the problem from being unhealthful to healthful, then actually they find that you can begin to reverse these problems and prevent these problems from developing. A colleague physician of ours, Chip Whitney, states it this way: third era medicine is about empowering another person to create personal health. See, that's Dr. Roizen's becoming rational, isn't it? Health is not just the absence of disease, but it's a state of vitality where we have the energy, motivation, excitement, and the hope of youth. And so now I want to transition to our world of dentistry. So as you look at these three photographs, on the top you see gingival inflammation and infection. And we look at that and think about the cause and understand about local bacterial pathogens. We also understand about patient's own host resistance or immune resistance. But do we think, when we see that, of something like, could there be diabetes? Is this a local reflection of something bigger going on systemically that may be interacting with the gingival complex and actually exacerbating or working synergistically with these bacteria to cause this type of breakdown? So we're expanding our thinking now, aren't we, from just what we see to what may be behind the curtain and underlying some other factors that could be even more important than periodontal disease. On the second slide, you see someone who has quite a bit of erosion of their teeth and wear. And so we see a combination going here of bruxism, grinding of the teeth, but also of acid erosion. Where would that acid come from? Well, most likely it's coming up from the stomach in the form of acid reflux or gastric reflux or GERD. And so when we see someone present, not only are we thinking, how would we restore these defects in the teeth, but we're also thinking about, could this be someone who has gastric reflux? Could this be someone who has an airway problem? In fact, we know that the majority of patients that have gastric reflux, that have sleep apnea, also, when they're making an effort to breathe and their posterior pharyngeal area is blocked and they're trying to breathe, but they can't get oxygen or air to pass, there's a negative pressure that can come up from the chest that can release gases and acids from the stomach all the way up the esophagus, into the mouth, and even into the nasal sinuses. And so what do we know about gastric reflux? We know that gastric reflux is the #1 driver of esophageal cancer. And we know that esophageal cancer is the fastest growing cancer in the Western world. There's an increase of over 1,500% of cases of esophageal cancer just in the last 25 to 30 years. We know that airway problems such as sleep apnea can be a tremendous source of inflammation throughout the body, as well as creating insulin resistance, type 2 diabetes, weight gain, cardiac arrhythmia, and risks that go all the way up to sudden death. And so are we actually looking in the mouth of someone who hasn't been screened or diagnosed with either one of these and yet has both? If that's the case, how important would it be for us to be able to identify that and to be able to get into the right hands for help? It would be tremendously important. This child in their primary dentition, you see, is quite a bruxer. And historically, through the years, if someone asks, why do children brux, we would say, probably because they have swollen tonsils and adenoids, and their breathing is not good. And so go look at their tonsils and adenoids, and that's true. That is a factor, and we should be looking at children and thinking about these things. But really, what would drive some of these problems with airway and even enlarged tonsils and adenoids? And I would like to suggest that we've learned that allergies in the upper airway and the nasal airway can create what's called upper airway resistance syndrome in newborns even, that will convert to mouth breathing, that will cause dirty air to pass over the tonsils and adenoids and cause them to swell and become inflamed and even infected. And bruxism is a form of protection in order to try to open the airway by moving the mandible forward and opening up the posterior pharyngeal area. So we think of bruxism as a type of parafunction, don't we, beside normal function. Actually, I would like to suggest that in many cases, if not most cases, it's not parafunction, it's protective function. It's an effort to open the airway so that oxygen can be received and we can stay alive. And so we would have to say today, if oxygen and teeth are in war, hopefully oxygen will always win, even if it's at the expense of teeth. But when we see wear on teeth on children or adults, we should be thinking, could there be allergies? Could there be upper airway resistance? Could there be airway problems during sleep? Could there be breathing disordered sleep that could cause bruxism as an effort to stay alive? And so Dr. Dawson was so tremendous at always asking why until you can't ask why anymore. That's part of the better way philosophy, isn't it? So we ask, why does TMD and TMJ exist? And why do malocclusions develop? And why do people brux and have sore muscles and headaches and poor sleep and gastric reflux and neck aches and crowded teeth and open bites and tongue thrusts and tongue ties and swollen tonsils and mouth breathing and periodontal inflammation? Why? Why do these things happen? We've become very good at trying to solve the malocclusion problem, but we often are not able to explain why people have a malocclusion, nor in the past have we really tried to that hard. And so I want to suggest, as Dr. Dawson always said, that dentists are the physicians of the masticatory system, but we want to go ahead and add and say, and beyond, integrating dentistry and medicine, and that we who are on this conference together, call together, would see ourselves as potential pioneers, teams focused on complete health. And we're going to call that integrative dental medicine. So yes, we're interested in diabetes and sleep apnea and gastric reflux and nutrition. These are critical parts of our patients' health, and they're critical parts of oral health as well. And so I believe the next frontier is integrative dental medicine, or what we could call third-year medicine. Okay, if that is true, how do we begin to work with this? Where do we start? That was one of the early challenges that we faced as we learned more and more and more. And at first, it seems overwhelming, like this is too big, too much. And so it can be something that puts us off a little bit. What we've done is we've tried to simplify this subject and say, all right, what would be the least common denominators that we could attend to that would be the most important? If we could just boil it down to, let's say, 3 key pillars or 3 key areas of focus, wouldn't that be good? And couldn't we do a lot of good for our patients and our communities? And so what would those 3 key pillars be? And that's what we began to study and came up with what we believe is an answer. The first pillar being inflammation and infection. That's kind of the low-hanging fruit, as I'll show you, of this whole subject, because we're all treating periodontal disease. And periodontal disease, as I'll show you, is a big player, not only in localized disease, but in systemic disease as well. And so we could start there. Another pillar that we could address would be airway, breathing, and sleep disorders. Of course, this is getting a lot of attention in dentistry, isn't it? We have a lot of courses in the US, and I'm sure in UK, on sleep apnea and how to make oral appliances for sleep apnea, and why people don't like their CPAP, and why dentistry might have a role in solving that problem. And so that's gotten a lot of attention. But I want to show you that it goes way beyond that. That's just the tip of the iceberg, because airway, breathing, and sleep disorders have everything to do with oral and dental health and malocclusions and temporomandibular disorders, sore muscles and sore joints and headaches, these sorts of things, and fatigue. And so we'll talk about that as we discuss together. The third pillar would be something that only we in dentistry know anything about at all. And it's what you and I have spent our careers focused on, and that is TMD and occlusion. Who is it that's going to address these problems in the head region that patients come in with? So many times we receive referrals from the ENT saying, we don't think it's an ENT problem, go see your dentist. You probably have TMJ or a TMD problem. And so, yes, that is our specialty, and we should accept that as our specialty. But here's what has become very exciting as we've been studying these three things and really digging into cause and effect and also solutions. And that is that we're learning that these are related. And in fact, the premise of this book, The Shift, is that these three pillars of integrative dental medicine are linked to each other, that we're finding as we begin to study and see patients clinically, and they come in with a TMD problem, and we ask the question, could there be an airway problem? Most of the time there is. And so the cross between these three subjects is tremendous, and that's what I want to speak about for the time that we have remaining together. So I see the next great frontier starting now as being integrative dental medicine, and that means not only us integrating a more complete picture of whole health of our patients in our concerns and what we're screening and testing and treating, but also it means more collaboration between us and our other medical colleagues who also have their special area of focus, but don't know anything about oral health, for example, or the role that that can play in complete health as they're looking at special needs that our patients may have. And so that's the challenge. And I want to share with you how we've attacked this challenge. And the first thing is this: whether you're in London or whether you're in Glasgow or whether you're in Manchester or in St. Petersburg or New York City, we all want to be calibrated, as it were. I mean, we all want to be capable of doing an equally excellent job of screening, testing, and diagnosing and developing treatment plans, don't we? And so what we've done is we've developed a checklist, and we'll share this checklist with you. In fact, I think it's been downloaded and sent to you already by Patricia. But this checklist is intended to be a simplified approach to being very thorough. And so as you look at the first page of this checklist, which is 2 pages, at the top, you'll see I just circled infection, inflammation, airway, breathing disorders, TMD, and occlusion. These are our 3 pillars. And so as you go down vertically in each column under each topic, you'll see on the left, you'll see history, signs, and symptoms. And then we'll list about 8 or 10 possible signs or symptoms that would be very common for these different 3 pillars, okay? So those will be asked of the patient before we ever see them. What I did was I took this block, which we're calling history, signs, and symptoms, and I cut and pasted it right into our history form. And so the existing history form we use, medical history form, and we just include a few more questions. Then when we see the patient clinically, we have 4 or 5 things that we're going to look at very quickly that will allow us to screen them and see, are there any red flags, both in the history and in what I see, that would lead me to think there could be a problem. So if the patient opens their mouth and they've got visual signs of inflammation, there's a red flag. If they come in and their neck is huge, and that's a high risk factor for having airway problems, there's a red flag. If they open and close and their joints clicking and popping, there's a red flag. So you see simple things, but We just want to make sure we're looking at everything. Then we have screening and testing that we can do. I'll mention a few of the real exciting ones to you today. And when we're together next year in London in September, we'll get into a great detail, and we'll even do some testing on each other while we're there. But screening and testing, when we see red flags, then we're going to go right into testing that can identify the specific concern or the degree of concern that's there, or begin to clarify that. So if you had a patient with a jaw joint problem, you would want to get a CBCT. You may, in some cases, want to get an MRI. If we have someone with visual signs of inflammation in the mouth, we may want to do a salivary testing that can go ahead now and help us to identify the key oral bacterial pathogens that can be driving that inflammation. If they're having signs of airway, breathing, and sleep disorder, how about if we do an overnight home sleep test tonight, and tomorrow we'll be able to review that and see if there's anything going on. And in the United States, we would share that information with a sleep physician to do the actual diagnosis. So then we're going to find out if there's a differential conclusion of anything going on in any one of these three key categories. We'll flip the page, and here on this page, we have a broad view of treatment options. And so that's how we're going to approach this. And it works very, very, very well. And we can all do the same thing Monday morning. And so I encourage you to download this checklist and to begin looking at it and studying it if you so desire by the shift. And the purpose of the book is as a manual to take you through each one of the items that's on this list and go through why they're there, the research behind them, how we use them, or how we use them to identify problems, and clinically what we do about it. So it's a manual workbook of this checklist, which is the outline of what we're talking about. So the subject that we're so familiar with, and we'll talk about more next year together when we have time, is TMD and occlusion. As you know, Dr. Dawson wrote the first textbook on this subject, Functional Occlusion from TMJ to Smile Design. It's considered the Bible of this topic. And so it's something that we have researched very intensely to create these texts and teaching principles. But now today, as we're talking about integrative dental medicine, I want to emphasize again that when we see patients with TMD and occlusal problems, now when we see signs of bruxism like we see here, one of the first questions I'm going to ask myself is, could there be an airway problem? We need to know, because we know that airway, breathing, and sleep disorders are one of the major drivers of this protective function that we call bruxism, either clenching or grinding. And so, yes, now we begin to look beyond just the tops of the teeth and inside the joints and what's going on with muscles. And when we see these malocclusion problems that we want to resolve, it drives us to think, how did this happen and why did this happen? And we often find with these types of problems that it's related to airway and breathing, sometimes upper airway resistance and mouth breathing and tongue thrusting and narrow arches and airway obstructions. And so we would ask ourselves, if we saw this patient, I wonder if there could be an airway problem. And so you see how this works. And now when the TMD patient comes in, pointing to the muscles or the joints and says, I have sore muscles. I wake up in the morning tired and fatigued, and I feel tired all day and uncomfortable and just can't think well. And I think I'm clenching. Then we're going to be asking not only what is the condition of the joint and what is its relationship to the muscles of mastication and to the dental occlusion as far as those being harmonized mechanically, but also we're going to be asking, could there be an airway problem, a sleep disorder that would be creating a release of stress hormones during the night and bruxism activity that could make the patient feel absolutely terrible, and they would come in with exactly the same signs and symptoms as someone who has basically a malocclusion, occlusal muscle type problem. So you see where we're going with that. We have a column, in our checklist, TMD and occlusion. And in that list, we, as you go down the columns, it's all the classic steps that you and I have learned in the past and the classic treatment modalities. But what we're going to do now is look at the whole checklist and think, and could there be an infection or inflammation problem? And could there also be an airway and breathing disorder? Because that will significantly impact our diagnosis and also our priorities in treatment and possibly our ultimate treatment plan. And so here on the second page, you see the occlusal disorder, TMD and occlusal disorders, phase 1, phase 2 treatment, all the ones that we've all studied together for 30 or 40 years. But now we also are going to be thinking, and what about the other 2 columns? Is there anything there that we should also be considering as important? So in the future, it's my belief that we'll be looking at TMD and occlusion with some additional concerns or perspectives. And one of those is that we'll be looking at the breathing dysfunction, occlusion, deformation, connection. In other words, the malocclusion as a result of breathing dysfunction. We'll also be looking at breathing dysfunction and bruxism and the TMD connection, because that can be a driver, a cause and effect relationship with bruxism and TMD. We'll also be thinking about TMJ deformation, that is internal derangements in the joint, disc derangements, osteoarthritis in the joints, and how when you have breakdown of the dimension of the joints, it's also going to create not only malocclusions, often developing anterior open bites, but also it's going to begin to impinge on the breathing complex in the oropharyngeal area that is collapsible. And so therefore, when you have dimension of the mandible moving in a posterior direction, in a more retrognathic direction, you can also begin to cause direct problems to the breathing apparatus. And that's true when the maxilla is underdeveloped as well. So I kind of tongue-in-cheek say, we'll be focusing in the future on the craniofacial, respiratory, TMJ, occlusal, cervical neck complex. And then we'll have additional collaboration, perhaps on a regular basis, with not only chiropractic physicians looking at C1, C2, physical therapy, and other specialties. So I'm not going to go into more detail today on the TMD occlusion, because I really want to focus on these other 2 pillars together for the remainder of today. Okay, so now let's transition into the second pillar, which is inflammation and infection. This is a super, super important topic. And I would want to point out to you that there's a lot of attention all through medicine, all through all disciplines of medicine and medical research on this subject of inflammation. Here's an article from the Mayo Clinic newsletter online, and it says, buzzed on inflammation. So we're asking the question, why do chronic diseases occur? That's a big why, isn't it? And so the statement by Dr. Brent Bauer is that inflammation is the new medical buzzword. It seems like everyone's talking about it, especially the fact that inflammation appears to play a role in many chronic diseases. So we in dentistry know the role of inflammation in periodontal disease, don't we? But we also have heard or know a little bit about the fact that oral periodontal disease can be a factor for risk in vascular disease, in bacterial endocarditis, and potentially causing problems with replacements of joints recently in the hips and in the knees. So we know that oral bacterial pathogens can travel through the bloodstream and cause problems in other areas. And yes, indeed, that's true. And that is a type of infection, but it's also a type of inflammation. We know that systemic diabetes is a major source of inflammation, and it also can influence periodontal health or disease. We know that nutrition and diet is a critical part of our health, and that poor nutrition and a poor diet can be a source, a direct source of systemic inflammation, just like toxins, just like smoking and nicotine can be a direct source of inflammation, just like airway and breathing problems during sleep, where oxygen levels are dropping, and therefore we get a turn on of the sympathetic fight or flight response, and the release of stress hormones such as cortisol from the adrenals can do havoc in creating inflammation throughout the body. And stress itself, in a very stressful world that we live in, stress itself can be a source of inflammation, as again, you release stress hormones such as cortisol that can really foul up a lot of things within the body. Lack of physical activity is a potential source of inflammation. Some have said that physical inactivity can be as bad as smoking. Your lymphatics are stimulated to remove toxins when you're actively moving your body. Your cardiovascular health is significantly improved, we know, when you're exercising 30 minutes a day, 6 days a week at an aerobic level, that it gives you a huge boost in your cardiovascular health. And so we see all around us, don't we? People that are inflamed, sore muscles, sore backs, sore joints, arthritis in the joints, osteoarthritis, rheumatoid arthritis. What are these? These are all diseases of inflammation. Interestingly enough, there is a wonderful book called Beat the Heart Attack Gene, written by Dr. Brad Bale, MD, and Amy Doneen, a nurse practitioner with her doctorate in cardiovascular risk. And in that book, Beat the Heart Attack Gene, they make this statement: systemic inflammation is the #1 factor in atherosclerosis and accelerated aging. So this is a critical subject. In their book, they use a wonderful illustration I'm showing you here called about a tree. And in this tree, you see the fruit of the tree is atherosclerosis, or changes within the arterial walls causing inflammation and buildup of inflammation and unstable plaque that can be released into the bloodstream and cause heart attacks and strokes, and even peripheral arterial disease such as wrinkling and erectile dysfunction and so many other things that we see, including memory loss. But in this tree, you see Bale and Doneen have put the trunk as inflammation. That's what we've been talking about. Inflammation is not the cause. Inflammation is the effect. Inflammation is the expression. Inflammation is when the heat gets turned up in the kitchen inside of our bodies because of disruption within our bodies, then that is a sign of breakdown and change that will occur. And I want you to notice here that one of the root causes, the true causes of inflammation systemically that can lead to atherosclerosis and accelerated aging, is endodontic disease and periodontal disease. And so if this is a root cause, who in medicine is going to address this root cause? Only us. And so with that, we want to understand that what we are working with every day in the mouth affects what's happening every day in the form of inflammation and atherosclerosis and changes that can cause chronic diseases in our patients' bodies. Bale and Doneen recently, I believe last year, published a second edition of Beat the Heart Attack Gene entitled Healthy Heart, Healthy Brain, where they're addressing more of what we're learning about inflammation's role in brain dysfunction in Alzheimer's and dementia. And so I highly recommend these books to you as great reading. They did an article that was published in a medical journal back in 2016, which was a really important article about high-risk periodontal pathogens and how high-risk periodontal pathogens can contribute to the pathogenesis of atherosclerosis. And here they talk about periodontal disease being generated by microorganisms that can create a circulating bacteremia that has been level A evidence proven, that is at the highest level of research proven, that it can independently be associated with arterial disease, and that this arterial disease is present in the vast majority of those over 30 years old, and that remains the #1 largest cause of death and disability in our world, in our Western world. And they identified 5 specific bacteria that are known to be drivers of this change in arterial health that creates what is called an inflammatory cascade. And we're going to repeat those words many times in the next the rest of our time together. Inflammatory cascade, and that periodontal pathogens are contributory to that. And so as we think about that very important statement and finding in that article, let's talk about inflammation and infection, and let's talk about the body's culture. As you know, from our mouths all the way through our digestive tract, we have more bacteria than we have cells in our whole body. So is it important that the culture of bacteria in our bodies be healthy and stable and balanced? And the answer is, of course. If you have an unstable microbiome throughout your digestive tract, you're going to be sick. We know that our digestive tract is responsible for 70% of our immune system. It directly communicates with our brain and our brain health and well-being. And so there's our health overall is dramatically connected to bacteria. Dr. Tom Neighbors, I'd like to introduce you to, as a microbiologist, researcher, dentist, who has been a father of what is now called oral pathogen salivary testing. And in his work and that of other microbiologists working with him, they have learned that now there are 5 key pathogens or bacteria in the mouth out of 700 or 800 we've identified, and we know there's many more, that are driving inflammation in the mouth and beyond. We call these the red complex, or the high-risk pathogens. We call them the keystone pathogens, or the high-risk pathogens, and they are AA, PG, TD, TF, and FN. So we could go into a whole half a day on this, but I just want to point out that from this article, for example, from 2021 in the Journal of Medical Microbiology. So this isn't a dental journal. This is medical information that's coming out of medical research and medical universities and research centers. They say these keystone pathogens create the most aggressive immune responses. They point out these 4. And what they've learned is that these 4 can go into bacterial plaque, can go into the microbiome, and they can actually influence all of the innocent bacteria to become evil, if you will, to become part of the inflammation and breakdown. And they do it through these sophisticated measures called cell signaling and signal transduction, through horizontal gene transfer, where actually these bacteria can transfer their genetic information into other bacteria in that colony of the microbiome. And they can do what's called quorum sensing, which is actually communicating with these other cells in the biofilm. It's quite amazing. And so the lesson here is, if you can understand the levels of the presence of these 5 high-risk pathogens, and if you can knock them down in their presence so that they're not causing disease, then you can basically knock out the disease altogether, and also the effects that go way beyond the mouth, as we're showing here. And so these 5 high-risk pathogens have been associated individually with a number of systemic problems that can be very, very significant and severe. And we call this the inflammatory cascade, coined by Dr. Bale and Doneen. And so we have inflammatory cascades coming from the mouth throughout the body. And the question is, well, how would we analyze this, and how would we address this, and how would we intercept this? And the answer is through salivary testing. So one of the things that's great about being in dentistry is we're right in the saliva, aren't we, all day? And how hard would it be for us to collect a saliva sample and send it to a laboratory where it could be analyzed for these 5 high-risk pathogens? We can get a report back telling us the levels of each, and then also have a strategy for being able to reduce or eliminate the presence of these 5 specific high-risk pathogens to the degree that we can actually create a healthy microbiome in the mouth, and therefore not be sending out pathogens systemically to the rest of the body. So here's a case, Dr. Tom Neighbors, did clinically, along with Laura Hooper, a wonderful, brilliant hygienist who has done more research than almost anybody I know on this subject. And so here's a patient, and through the strategies non-surgically that they implemented, you can see the elevated levels. 3 out of the 4, 3 out of the 5 are high in their presence, and 1 is at a moderate level. And 6 weeks later, after treatment, you see 1 left at a low level, and the others are not detected at all. It really begs the question, if these 5 are driving the ship of disease, then if you're able to get them down to this level, have you actually eliminated the disease? Can periodontal disease be controlled? I could be stronger and say, could it be eliminated? Could it be cured? Maybe we could say, could periodontal disease be put in remission? And so those are the questions that we're looking at. And would this improve cardiovascular health? And the overwhelming answer to that answer is yes, absolutely. It can improve cardiovascular health. And so Dr. Neighbors, in his teaching, asked the question, can periodontal disease be cured or arrested or put into remission? And he shows an example. This is when we were using 11 and 12 oral pathogens in our studies, in our analysis through salivary testing. Now we're only using the 5 because we realized that the others that were recognized as harmful were being driven by the 5 high-risk pathogens. And so here's a patient seen by Dr. Neighbors with some elevation. And here's that patient 4 years later, and look at the profile on the salivary test. Nothing above the black line, nothing at a risk level that is dangerous in any way. And so is this patient going to develop periodontal disease? And the answer would be, if they stay where they are right now, never. And so Dr. Neighbors has cases he can show of 20 years follow-up where the profiles from the salivary testing, which is actually measuring the presence of pathogens, not just looking and doing periodontal probing, but actually quantifying this with the presence or the lack of presence of pathogens to see what we get. So here's a practical example. This is Dee, a patient who came to see us with severe breakdown in her mouth, and she had infection, she had decay, she had loose restoration, she had severe periodontal pocketing to the point where we had to go ahead and face the fact that we were not going to be able to save her teeth. So it was decided that the treatment plan would be to remove all the teeth, place 5 implants on the top and 5 on the bottom, and do a hybrid bridge on the top and bottom that would be fixed. And so often we would think, well, you're removing the teeth, therefore you're removing the disease, correct? Because once you remove the teeth, then those bacterial pathogens have nothing that they can harm. But we're finding that of these 5 high-risk pathogens, at least 3 of the 5 can cause peri-implantitis, can cause periodontal disease of the implants. And we've seen that, haven't we? Bone loss around implants, even failures of implants. So here's the way that we would address this today. Before we initiate our restorative therapy, starting with surgery, we're going to go ahead and do a salivary test for high-risk pathogens, and we're going to address those now before we remove the teeth, and then we're going to get those under control before we do extractions, before we place implants, and before we restore. So this would become our new protocol. This is so important in cardiovascular health and risk factors for atherosclerosis and heart attacks and strokes. And so I want to introduce you personally to Dr. Brad Bale, and I've asked him to share with you his perspective on the role of dentistry and in medicine and in his work as a cardiologist. So just listen to this.
Yeah, you need to understand, there's no question, oral health is a critical element in beating the heart attack gene, not only heart attacks, but strokes. And actually what we're finding now that's even more exciting, it's an integral part of preventing microvascular disease, which is what accounts for almost all the severe diseases of aging, from dementia to heart failure to kidney failure, erectile dysfunction in men. Oral health is a vital element in that as well. Not just the big dramatic, oh, you had a heart attack, you had a stroke, but the more subtle damage that occurs over decades and then robs us of our health during the last 10 to 13 years of our life. If you want to have a health span that matches your lifespan, you better have excellent oral health. You know, we published the paper showing how the high-risk periodontal pathogens actually cause arterial disease. It causes arterial disease, of course, is going to heighten the risk of not only heart attacks and strokes, but that long-term subtle microvascular disease leading to those chronic diseases I mentioned earlier. So everybody really needs to be seeing an oral healthcare provider who is aware of that. Their team is literally helping to save lives by diagnosing high-risk periodontal pathogens and then managing those to eradicate them from our mouth. It's extremely important. And then the endodontic disease, of course, is vital as well. And we have great evidence. Endodontic lesions like periapical abscesses can trigger a lot of heart attacks and strokes. We even have evidence now indicating they're triggering peripheral arterial disease events as well. So the endodontic disease is very important too. And you have sophisticated tests to diagnose both the high-risk periodontal pathogens and endodontic disease. So you've got your salivary testing for DNA to identify the pathogens that can drive that periodontal disease with high-risk pathogens. And you've got the 3D cone beam, which is 96% accurate in picking up periapical abscesses. So oral health is critical for arterial wellness, for maintenance of health throughout our lifetime.
So you hear from one of the leading researchers in the world that oral health and the work that we do to prevent oral infections from spreading through the cardiovascular system, through the vascular system throughout the body, is critically important. And he points out using imaging to look for periapical disease and using our salivary testing for looking at the specific DNA of the particular pathogens that we know are the drivers behind all of this. So the next frontier, this is it. This is definitely it as far as a huge contribution that we can make. And so let's transition a little bit now to inflammation and infection, talking about the body's chemistry lab. So we talked about the body's culture and how important it is to have a healthy culture throughout the body. But now let's talk about the chemistry lab, because we know too well all the chemistry that goes on in the body, how critical it is. And we know what the fuel for all of these elements are that drive the ship, that drive the engine, that create the new cells in our bodies and the operations within each cell, and that is the food that we eat. And so the food that we eat as provided in nature is universally anti-inflammatory. And we've known this going back as far back as 400 years BC when Hippocrates said, "Let food be thy medicine and medicine be thy food." So we know that what we ingest can be a resource for reversing disease. And I shared with you the work of Dr. Esselstyn and Roizen and others that have shown that when they take sick patients and put them on a super, super, super healthy diet, that their body actually begins to respond and their arteries begin to respond favorably, and the inflammation is reversed and the atherosclerosis can actually shrink in a positive way. On the other hand, we also know that when we eat poor foods choices, that it can be a source of inflammation. And part of the problem is that the body recognizes certain chemistry that comes from food in nature. But when we change that chemistry through additives and preservatives and modifying the foods and refining the foods in such a way that it's basically unrecognizable, what will happen is the body has a tendency to store that unknown substance either in fat or in the liver. And in both places, it can do damage. And so we see a culture, a generation today, don't we, because of poor chemistry, because of poor fuel being fed into the engine, that we see disabilities literally developing in young children and young adults and in all ages as a result of that. And the end game of all of this is chronic disease, particularly vascular disease, as it goes throughout the whole body. And it's manifested very often as pain, sometimes from head to toe. And we're very familiar with pain, aren't we? The top 6 or 7 selling drugs on the planet are anti-inflammatory medications, either for muscles, joints, arthritis. And so we understand that this is something that is universally present. And this is a source of another type of inflammatory cascade. And so this is something that we want to be acutely aware of. In fact, these are the different areas of inflammation sources that we looked at relative to dental medicine that seemed very appropriate. A pro-inflammatory diet, yes, we could address that. In fact, we have a nutritionist working with us now who comes into our office, who works with our patients, who is also a lifestyle coach. Disorder breathing, which we'll talk about next, is a huge subject. Oral pathogens, of course, is right in the middle of this topic. Physical inactivity, toxins and smoking, blood sugar dysregulation, and stress. We describe these things as being part of the inflammatory cascade overall, and we have borrowed a term that is inflame aging, that is accelerated aging due to inflammation. An example of inflame aging could be periodontal disease or diabetes or disorder breathing. And so with that, we have focused on this as a critical part of this model that we want to build out throughout the dental community. So the integrative dental medicine dental teams are gatekeepers for systemic inflammation. That's the way that we want to build this model out together with you. And so we go to the checklist and we see another column, and this column or pillar is infection and inflammation. And so we've talked through a few things, but here are the general questions that we ask patients, what we look for, things we can screen and test for. And if these things are positive, then we can implement treatment actions or steps. And that may include the dentist and periodontal therapist or hygienist, and certain aspects of this, from eliminating oral infections and caries and diseased teeth and periodontal problems. But also we would want it to include lifestyle coaching, whether it is involving us or someone else that we bring on our team that we work with. It could be a nurse practitioner or a physician or a nutritionist or a lifestyle coach that works with patients in their overall lifestyle strategies. But here we're looking at an anti-inflammatory diet and an anti-inflammatory lifestyle, a lifestyle that's filled with activity and purposeful management of stress and sleep hygiene and smoking cessation and the avoidance of toxins. As we look forward, I think that we're going to see some new and developing areas of focus for all of medicine, including dentistry, that would be understanding the oral pathogen arterial disease connection. and understanding the role of salivary testing, not only for oral pathogens and HPV and even COVID, but there are over 250 known tests right now for a variety of disorders throughout the body that can be understood through salivary testing. So salivary testing will rival blood tests and urinalysis in diagnosis. The question will be for us, so what do we want to test for? What do we want to limit our testing to? There are actually certain kinds of cancers that you can diagnose through salivary testing. So we may not want to be doing that, for example, but we could if we wanted to. So advanced periodontal protocols will be included. Blood, urine, as well as salivary testing analysis may be something that is done in dental offices or through dental offices ordering. Systemic inflammation will be a big topic, both the pro-inflammatory diet as well as stress management and toxins, physical inactivity, oral pathogens, blood sugar dysregulation, metabolic syndrome, which is basically gaining weight around the midline, which is a reflection of taking in more calories than we expend, which is often a reflection of a poor diet, of physical inactivity, sometimes poor sleep that throws off our hormonal balance can be part of that. But with metabolic syndrome, you see an increase in blood pressure, an increase in blood sugar levels, an increase in waistline, an increase in cholesterol. And basically, metabolic syndrome is pre-diabetes. And so what follows the development of this weight gain and changes would be ultimately diabetes and potentially obesity, which we know is a pandemic throughout the Western world. Nutritional counseling, a dietary supplementation will be something that I think we'll see frequently in dental offices, along with collaboration with the integrative physician, the nutritionist, the family physician, as well as our periodontist and endodontic colleagues. So I want to share with you a brief video. This is by James Nestor. James Nestor is a journalist in the US, and he's taken a strong interest in the subject of breathing, and he calls it Breath, the New Science of a Lost Art. This was a New York Times best-selling book back about 3 years ago. It's gotten around the world, I believe, and it's been read by many, and it's all about what we're about to talk about. But here's at a conference that is not a dental conference, but I want you to hear what he says.
The biggest change happened in the last 400 years. That's when we went from having this forward facial growth to having this retruded and recessed facial growth. So that's about 300 years ago. That's about 200 years ago. And now about 90% of us have a facial growth that is recessed and flat, much like mine. So if you drew a line from the top of the ears and a perpendicular line in front of it, almost every single ancient skull is above that line. And now about 10% of the population, or 5% of the modern population, is below that line, sometimes way below it. So here's another way of looking at it. This woman represents the sort of facial growth that we had about 500 years ago. As the centuries pass, she starts representing where we are now. So what happens when your face grows backwards and your mouth grows smaller? Teeth have nowhere to go, so they come in crooked. They have to fight for space.
So here we have a journalist, a layman, who's gone around and visited with many of the colleagues that I've been studying with and learned from them, and now is throwing this out to the public, where if the average patient went in to see their dentist and said, "Why are my teeth so crooked?" the average dentist would say, "We really don't know. Maybe it's genetic. Maybe it's your family tree. Did your parents have very crooked teeth?" See, we would be looking more at something that is totally uncontrollable, whereas today we would be looking at it as more of a factor of what we would call epigenetics, EPI genetics, and that is the environment's influence on genetic expression and growth and development. So, for example, a study was done at the University of Michigan in the late 1970s where they put silicone plugs in the noses of young rhesus monkeys. Some couldn't convert to mouth breathing and they died. Others, when they converted to mouth breathing, the low tongue posture that they had, they would see excessive maxillary pre-maxilla growth, and they would see crowding of the dental arches and narrowing of the dental arches because of the change in the breathing pattern. And so that would be an epigenetic or environmental influence on growth and development and expression genetically in one generation. And so we're seeing that. And when we get together next September, we'll go into a lot more detail about this retruding or recessing face that we see both in the maxilla and the mandible. But breathing, airway, and sleep are a critical subject for us. And so you see this second pillar in our IDM checklist, which is under breathing, airway, and sleep. I want to show you this brief video on sleep and the stages of sleep, and just remind you of the importance of sleep and what happens during sleep.
Right. Almost everyone on the planet enters into a state of unconsciousness and paralysis. But what is really happening inside?
I believe we have lost sound. Could you turn your microphone back on? I think that might solve the problem.
The body creates chemicals that render it temporarily paralyzed, so that we do not act out our dreams. In this stage, the brain is extremely active, and our eyes, although closed, dart back and forth as if we were awake. Humans roughly spend 1/3 of their lives asleep. Modern lifestyles, stress, and the proliferation of technology mean that people are sleeping far less today than they were a century ago. Sleeping less than 7 hours per day is associated with an increased risk of developing chronic conditions, which could reduce life expectancy. So for a healthier, longer life, get some shut-eye.
We used a nice British model for that voice, and I think she did a great job. So you see the critical importance of sleep, and let's see here. There we go. When it comes to this topic of breathing disorders and breathing disordered sleep, it's nice to kind of break it up into different categories that we see. And so we've broken this down into 3 demographic populations to focus on young children from birth. And often they will manifest disturbances from allergies, poor breathing, upper airway resistance syndrome, where they can't breathe through their noses, mouth breathing, and poor sleep that will manifest themselves very often in disruptions of their coping and their cognitive and social behavior. And so they often will get mislabeled or misdiagnosed as ADHD. And of course, when you have a child diagnosed with attention deficit disorder, we give them amphetamines for that. which actually would not be helpful at all for a child suffering from allergies, breathing, and sleep disorder. Young adults with airway problems and sleep disorders often will present with TMD type symptoms of sore muscles and headaches and fatigue. Middle-aged adults, our classic obstructive sleep apnea patient, will sometimes present with foggy memory and even the fear that they're developing early Alzheimer's. And in a sense, they are, but it's different because it's more of a lack of oxygen and a dysregulation of neurotransmitters in the brain that are causing this breakdown that occurs. And so, and it's reversible. Here's the study about the monkeys. And what they found was that in their work that these monkeys acquired a long, narrow facial appearance and dental occlusion compared to their controls. And the research done at University of Michigan over 20 plus years, James McNamara, who headed that program, concludes or summarizes their work by saying, there's a relationship between upper airway obstructions, that is nasal, and undesirable dental and craniofacial development. Significant improvements are seen when the obstructions are removed. And so Kevin Boyd, a friend of mine at Lurie Children's Hospital in Chicago, a pedodontist who has focused his work on children's airway and sleep problems, sent me these pictures of 3 of his patients. On the left is one, on the top right is one, and on the bottom right is one. They all have a common problem, and that is disordered mouth breathing and breathing disordered sleep. But you see how it manifests itself differently from very crowded to the strong tongue thrust to the strong bruxer. And any situation like this, I would recommend that if you have someone with a significant malocclusion, you be asking yourself, could there be an airway problem? Roger Price is a brilliant behavioral physiologist from down under in Australia, originally from South Africa. And he words it so beautifully, and I want to just share with you what he says. He says, dairy, let's say in a child, might cause an allergic response, which makes the child mouth breathe because of nasal congestion. Now, it's the mouth breathing that causes a lack of filtration through the nose and cleansing of the air through the nose, now allowing airborne bacteria to settle and flourish where? In the back of the throat. It increases in volume the dirty air over those lymphoid tissues of the tonsils and adenoids. It increases inflammation and congestion in those locations as a result of overbreathing. And then the lack of release of nitric oxide. Nitric oxide is considered the miracle molecule in the body by many researchers. I'll describe it more to you in a moment. But it is released from the paranasal sinuses into the nose, and it actually kills bacteria and dilates the airway. And so you lose that if you breathe through the mouth. You diminish diaphragmatic breathing as you breathe shallow from the chest, leading to a reduction in lymph flow to the tonsils and adenoids, where that lymph flow will remove toxins, so toxins build up. Restoring nasal breathing is a must after eliminating the Y, which is the allergic trigger. And so shut the mouth and get the diaphragm working again, and nature protects the system. So what's the story of nasal breathing and mouth taping? I don't know if you've heard of mouth taping or not, but it's gotten a lot of press. In fact, the person who I've learned the most about this from is from nearby Ireland, in Southern Ireland. That is Patrick McKeon. And so let's talk about mouth taping. Here's Patrick and his first book, which was entitled The Oxygen Advantage, written in 2017, is about proper breathing through the nose and how breathing through the mouth is actually dysfunctional breathing and unhealthy breathing. And so in his book, I've highlighted a couple of pages, which I share with patients that are having sleep problems and breathing problems. And it says this: over the years, I've introduced taping of the mouth to thousands of people with incredible results. Unless you breathe calmly through your nose at night, you have no idea what it feels like to have a great night's sleep. Taping the mouth at night is a simple but very effective technique. And while it may sound a little strange, it's well worth getting used to. And he talks about how most people can tape their mouths as long as they can breathe through their nose, obviously, and they will be able to convert to the habit of breathing through the nose, typically in about 3 months. Wearing tape, it says at the bottom, across the lips during sleep or when alone in your house during the day gradually trains the body to adapt to nasal breathing both day and night. Spending a guaranteed 8 hours breathing through your nose while you sleep is an opportune way to re-educate your respiratory center to adjust to a more normal breathing. Nitric oxide is such a powerful influence in cardiovascular health that 3 pharmacologists received the Nobel Prize in Science for the discovery of its role back in 1998. And they found that nitric oxide is a very important mediator and inflammatory marker in human upper airways. There's an enzyme responsible for the production of nitric oxide, and that enzyme is present both in the nose and in the paranasal sinuses, but much more higher levels are found in the sinuses of the nose. And so with this work, they found that healthy paranasal sinuses and the epithelium lining of those sinuses expresses nitric oxide synthase, which continuously generates large amounts of nitric oxide, which have a potent vasodilating effect in the nose and all the way down through the lungs and even into the vascular system, as well as an antimicrobial effect. So there's a couple of ways that you can get nitric oxide into your body. The higher the levels of nitric oxide, the better. So one, we just said, is through nasal breathing. Another is through foods that are rich in nitrogen. And so here you see some of the examples, and probably most all of us have heard about, if you want to improve your heart health, eat a lot of kale, but also arugula, Swiss chard, spinach, beets, cabbage, cauliflower, carrots, and broccoli have been associated with high levels of nitrogen. And the release of that nitrogen in combination and synthesized in your body, even working with bacteria in your oral cavity, will convert to nitric oxide, which will be disseminated through your body. One of the things that's been learned is that we tend to see over time a higher incidence of sleep apnea in men. And yes, it can be weight gain and more fatty deposits around the pharyngeal area, more laxity of the soft palate tissues, et cetera, that can be an influence. But we also see that over time, the production of nitric oxide declines with age. And so we see both of these kind of go together, don't we? The person who snores, the middle-aged guy, the person who has sleep apnea, the middle-aged guy, mostly tends to breathe through the mouth. And so with that mouth breathing, you're going to get diminished nitric oxide production. And so could that be a major factor or a significant factor in aging? Well, you can measure your nitric oxide levels using a litmus paper in your mouth, and you just wet it with your saliva, and you can look at the different colors from very mild pink, almost white, to a very rich, dark rose type color when the nitric oxide levels are higher. Here's an example of a discussion on that, which was published on the internet, where they were talking about an experiment that one anecdotal individual generated, which was without any mouth taping, their color of their nitric oxide or presence of nitric oxide was very weak in their mouth. They just did mouth taping only and found that the nitric oxide levels went up with the test strips. And then when they added supplements of nitric oxide, such as you see here, there's different companies that'll make dietary supplements of nitric oxide, then the nitric oxide levels went up even more. And so boosting nitric oxide is a very important subject. It relates to what's going on in the mouth and the oral cavity, in breathing and nasal breathing, in what we eat. So a nitrogen-rich diet would be number one for boosting nitric oxide. Breathing through the nose would be right there with that, including mouth taping if necessary to stimulate that. Nitric oxide supplementation is something that could be taken throughout a lifetime. And then a healthy oral microbiome, because it's been shown that in the oral microbiome, you can actually generate nitric oxide that can reduce blood pressure. And so nitric oxide is made in the body by a conversion of arginine to nitric oxide by that nitric oxide synthase we said was present in the epithelial lining of the nose, but also in the oral cavity, oral bacteria that are commensal, that work in a cooperative way with us, they can host nitric oxide production by reducing dietary nitrate to nitrite via what's called the bacterial nitrite reductases. And so unreduced dietary nitrate is delivered to the oral cavity through saliva. And here's what is very interesting for us is that studies have shown that you can disrupt this very positive production of nitric oxide through certain oral antiseptics that result not only in a reduction of the production of nitric oxide, but also in an increase in systolic blood pressure. So, for example, they did a study with chlorhexidine, and chlorhexidine was used for a week, and it was associated with a change in the bacterial communities, a reduction in certain bacteria, and also in a rise in blood pressure, and a significant rise in systolic blood pressure after just 1 week. When chlorhexidine was not used any longer, and there was a recovery period where we had a regrowth of oral bacteria and a regrowth of that nitrate reducing bacteria on the tongue, they found that as those levels went up and the production of nitric oxide went up, that the systolic blood pressure went down. And so how much are we going to be learning as we go forward about all of these interactions? We use a plant-based oral antimicrobial that targets aerobic bacteria. I don't think it's available right now in the UK yet. It's called Stella Life, but it's an excellent product, and we've seen that does not have that effect that chlorhexidine does in a negative way. Okay, so here's your next TMD patient. She comes in saying, I feel terrible. I wake up in the morning, I'm tired, my muscles are sore. Sometimes I have headaches in the morning, and I hope you can help me. So this is our TMD patient. So let's go home tonight and watch this patient sleep. You can see she's mouth breathing. She's breathing shallow from the chest. She's got obstructions you can hear. As she tries to drop into deeper sleep, it gets disrupted. When she's moving around, it's because she's trying to find a place that she can get comfortable. So watch how much she moves as she moves her head. She's going to move her arm. Just help me breathe, help me breathe. So she came in to see you in the morning and she said, my muscles are sore. See, traditionally I would say, oh, well, you've been clenching and grinding, you need a splint. We're going to put a splint in your mouth, and that's going to even out your bite, and that's going to make all the difference. Do you know that there have been studies done that show that when someone has sleep apnea, and you put in a traditional centric relation splint, that in half of the subjects that were studied, their sleep apnea worsened by more than 50%. That means if you had somebody with mild to moderate sleep apnea, and we diagnosed them as TMD, which just means sore muscles and maybe an occlusal problem, and we put in more acrylic in their mouth, we actually may be putting them at risk for elevating them from mild to moderate to severe sleep apnea. And so the point here is this: diagnose, diagnose, diagnose. Whenever we see a patient come in that says, my muscles are sore, I have headaches in the morning, my sleep is terrible, I'm tired all day. One of the first questions we should be asking ourselves is, I wonder if there could be an airway problem. And so, is this an airway breathing disordered sleep problem? Is this an inflammatory cascade that we're observing with the release of stress hormones and the elevation of stress throughout the whole body as a result of the patient's brain saying, I'm choking to death here, and therefore the heart rate goes up, stress hormone release goes up, and everything else just gets out of whack. Let me give you another example. This is a 21-year-old that was referred to me for TMD, which of course is not a diagnosis. Saying someone has TMD is like saying they have elbow, or you've got a bad case of stomach. There's no diagnosis there at all. And so there is no one-size-fits-all treatment either, is there? And so this TMD patient came in to see me saying her chief complaint was sore muscles and fatigue, and particularly in the morning. But she says, last week, it hit a crisis point where I woke up in the middle of the night with distressed breathing, and I felt like I was dying, to the point where I went to the emergency room in the middle of the night, panicked, and they tested her, did EKG, all kinds of tests, and they said they found nothing, and that it evidently was an anxiety attack that she had had in the middle of the night, and therefore they gave her an anti-anxiety prescription and sent her home. Do you feel like we've gotten to the root cause of the problem? No. So now we're going to see her and have her open her mouth and raise her tongue up as high as she can. And I see 5 things right now that are possibilities for airway breathing and sleep disturbances. Can you see some? Let me point them out. Number 1, she has a severe tongue tie that is highly associated with future airway breathing and sleep disruption. Number 2, she has a scalloped tongue. About 70% relationship or correlation has been drawn between a scalloped tongue and some lack of room of the tongue in the airway, in the oral cavity, and airway and breathing problems. Number 3, Mallampati-4. That is, her soft palate is behind her tongue and you can't see her uvula at all. That can be associated with up to a 90% chance of having some type of airway obstruction. Number 4, her maxillary arch is omega shaped. You see how her premolars and even first molars are kind of pinched in because her tongue doesn't go in the roof of her mouth and spread out her arch. And that is highly associated with mouth breathing, which she is a mouth breather, and with dysfunctional breathing daytime and night. And 5thly, you won't see this easily, but she has incisal wear on the right canine, lateral, and central. And that's true on the top and bottom as she goes edge to edge, forward and protrusive, and even beyond edge to edge. Why would you brux or grind in an edge to edge or beyond position anteriorly like that? Not because of occlusion or anterior guidance, it's because of airway obstruction and an effort to open that airway. And so we see these signs, don't we? And we're diagnosing things or screening and finding things that even the emergency room physicians don't see, even the specialists don't see, even the family physician doesn't see. So when we look at a patient like this, and we see tooth damage and acid erosion, and this is a bruxer who comes in reporting some symptoms of TMD, then we should be thinking gastric reflux, and we should be thinking upper airway resistance or sleep apnea and the resultant inflammation from that. And we know that gastric reflux is very dangerous as far as its risk for esophageal cancer. And we know that upper airway resistance syndrome and sleep apnea are very dangerous from the standpoint of releasing stress hormones chronically in such a way that we can develop insulin resistance and type 2 diabetes and cardiac arrhythmia and on and on. And so when we as dentists look in the mouth and we see these signs, then we are beginning to uncover something that's much, much larger than what may be going on in just the mouth. Here is an example in the back of the mouth where we see inflammation, we see a scalp tongue, we see inflammation in the tonsillar area. This is signs often of gastric reflux and inflammation there that is caused by those insults. So all of these things together point out to how inflammation and infection, TMD and malocclusion, airway, breathing, and sleep are linked to each other, and they are linked to the inflammatory cascade and to inflame aging in our patient population. When you look at a shoelace, here at the tip, there's a name for the tip of a shoelace, and it's called an aglet. And when you look at chromosomes, at the tip of each chromosome, there's a protection there, just like an aglet, and that is known as telomeres. You've all heard of telomeres. And so just like the little plastic aglet protects the shoelaces from being frayed, so the telomeres at the end of our DNA strands protect them from becoming frayed and breaking down. And actually, we know now that the breakdown of telomeres is the cause of aging and is an essential part of cell aging. And so one of the things that's been learned in the older population is that hyperbaric oxygen treatment actually helps preserve telomeres and can dramatically slow aging. Here's an example of a clinic in Florida where they, and this is the actual clinic module where these older retired individuals will come and do hyperbaric oxygen therapy, and they're finding that they're slowing down their aging. They're having effects on the development of dementia and Alzheimer's because of reoxygenating at a high level of the brain tissues, and just some amazing work. And I show this to you just to point out the importance of oxygen throughout a lifetime and how oxygen can be directly related to aging when it's diminished. And so often it is due to poor breathing and poor sleep. Here's an example of a patient after this conversation we're having together. I hope you'll look at it and say, boy, that's scary, because when we see that maxillary arch that's that constricted, what does that tell us? Well, we see a severe dental malocclusion, right? But the why behind the severe malocclusion could be childhood allergies that led to upper airway resistance syndrome that caused a conversion to mouth breathing and tongue thrusting and craniofacial dental deformation. But also associated with that potentially could be inflamed and infected adenoids and tonsils, chronic breathing disordered sleep, chronic release of stress hormones, chronic hormonal imbalances during sleep, chronic fatigue and poor memory, and other signs like ADHD and TMD and obstructive sleep apnea and type 2 diabetes and high blood pressure and cardiac arrhythmia. So just looking at that maxillary arch, I would want to ask, I wonder how the quality of the life is of this individual, and even if what we're seeing is a reflection of things that could affect their future life expectancy. Dr. Dawson always referred to the corridor where the teeth fit as the neutral zone. That is the opposite forces of the tongue pressures out and the cheek pressures in. And when you have a balance of those two, you're going to have a nice, well-rounded, fully developed dental occlusion. And the tongue will be posturing in the roof of the mouth while the mouth is closed and you're breathing through the nose. And so when we see malocclusions like this on the maxillary arch, those should be red flags for disordered breathing and possibly disordered sleep and oxygen desaturation potential during sleep, which can create that inflammatory cascade. And so these are the things now that we in the past had not been able to answer that we're beginning to understand very clearly. And as we research these things and say, could there be an airway problem? We're finding there are lots of airway problems. With airway concerns, then we're going to be treating these problems in one of two ways. We can manage these problems, and there you're thinking about things like the CPAP, and you're thinking about things like oral appliances that move the mandible and the base of the tongue forward to try to open up the posterior pharyngeal area. You can use nasal strips and nasal dilators. They can sometimes help as well. But understand together that management of these problems is not a cure. Management is just management. And in fact, in managing these problems in these reversible manners, we found that sometimes the risk for cardiovascular disease and heart attacks has not really gone down. So there's also resolution protocols whereby we're expanding the upper airway, the nasal airway, sometimes through surgery in the nasal airway if necessary, or through going back to nasal breathing can sometimes be a solution. Expanding the upper airway, posterior airway, sometimes even including the removal of tonsils and adenoids in children if necessary. Tongue tie release, expanding the dental arches, getting the mouth closed, using oral myofunctional therapy to train people to breathe through their nose and to properly swallow and to put their tongue in the proper position. So these are all ways that we are working with airway. So as far as the future of this subject of airway and breathing, I see nasal allergies as something that is very important and very common across our societies, as something that can create congestion and the conversion to mouth breathing as a result of upper airway resistance syndrome. Upper airway resistance syndrome is a milder situation that is not sleep apnea, but it's where the patient has problems breathing through the nose to the point where they prefer to breathe through the mouth. They may have some stoppage in breathing, but it's not as severe as full-blown sleep apnea. We'll get into much more detail when we're together next September. But this is, I would call it this. It's like pre-diabetes is to diabetes. Upper airway resistance syndrome is to sleep apnea. Most people that have upper airway resistance syndrome will very often go on to develop sleep apnea. So an emphasis will be placed on nasal versus mouth breathing, on tongue posture and swallowing, on tongue ties that are severe being released to free up the tongue to go in the roof of the mouth and properly function as nasal breathers. Of course, obstructive sleep apnea. And then the relationship, which is very closely tied together between obstructive sleep apnea and gastric reflux, and also collaborating going forward as oral specialists, working with allergists, working with ENTs, working with sleep physicians, working with oral myofunctional therapists and maxillofacial surgeons and gastroenterologists. I've worked with all of these specialties as we've become involved in focusing on this field. And I can tell you it's also been a great boon to increase the size of our practice because of the referrals that we receive from all over our community from the medical specialists who see us as a specialist in dental medicine and oral medicine. So we put all this together that we've been briefly discussing today, and we see how the inflammatory cascade throughout the body can come from local inflammation and infection, from local airway and breathing disorders, from local TMD and malocclusion problems, and that the inflamed aging is the consequence of that. And that's what we're all trying to slow down, isn't it? To decrease aging, to live at a level of health throughout our lifetime, and not to gradually get sicker throughout our lifetime. And so that's the battle that we're fighting, and that's what we're committed to. The whole treatment goal would be to reverse this inflamed aging process. And so as we conclude this discussion, I just am so encouraged because for a number of years now, I've been trying to promote the idea that dental teams are oral health specialists and gatekeepers of systemic inflammation. In my speaking around the United States at many meetings, this has been the focus for the last 7 or 8 years. I was so thrilled this year at the Florida Dental Academy meeting in Orlando, Florida, that the theme of the meeting was dentistry and systemic health. And they came to me and said, "Hey, did you see our subject, we're going to have nutritionists and sleep specialists and different ones talking about all of these things that you've been encouraging us to talk about. And that was so rewarding. So this train has pulled out of the station. In fact, this is Dr. Raymond Colmia. And Dr. Colmia is the executive director of the American Dental Association. And Dr. Colmia is so excited about the subject of dentistry being a primary care focus of whole medicine. And so they are committed through the American Dental Association to promoting this. In fact, they had an article that just came out, as you can see, October 21st. You can look at this on the ADA News on the internet. And the title of the long article, probably 7 or 8 pages, was Medical Dental Integration Emphasizes Mouth-Body Connection. Dental providers look at improving overall health outcomes through increased collaboration with physicians. And so this is music to my ears. I am just so excited about what we see beginning to take traction and grow. And I would love to spend time with you to talk about these things and learn more together. And so if there are any questions, we have about 10 minutes and I am done. So let me look here. Any questions out there? I'm looking at our chat.
I think there's one from Roop Witt.
Let's see.
First one was in case of TMD, I often find that nocturnal occlusal appliances can cause patients to mouth breathe, leading to disordered breathing. What is your experience, please?
That can be true. And what my experience is what you're saying is exactly right. And only in the last 3 or 4 years has there been an emphasis on the importance of nasal breathing. And it's strong evidence now. And once you begin to look at what happens when you breathe, it's pretty obvious that nasal breathing is the way to go. So what I would do if I had a TMD patient who now was mouth breathing because of the appliance, I would want to try with them to use tape. And so we use a very light, it's called paper tape, and it's not very sticky at all. Please understand, we're never going to recommend tape over the mouth on somebody that can't breathe through their nose. That's clearly obvious. So what we would do is take paper tape and give that to them, and they place it horizontally all the way across their lips, past the corners of their mouth, so that they can't breathe through their mouth. Now, with paper tape, if they want to open their mouth, they could. So it is in no way dangerous. But what we would do is say, put that on 30 minutes or an hour before you go to bed and just experience it and make sure you're comfortable. In fact, you should be more comfortable with the tape on your mouth than you are without. You should find that if you have any congestion, that congestion actually feels like it's being relieved and that you're less congested, because you will get congested if you don't use your nose because of the lack of release of nitric oxide and the lack of flow and usage of that whole nasal apparatus. But when you breathe through the nose and release nitric oxide, you should actually feel better. And so then I would ask them to sleep with that paper tape over their mouth. I will add to this about TMD that in a conversation with a number of colleagues around the world that I correspond with, we have found that when we have seen particularly young adults and particularly females, which is primarily our population of young TMD patients, that we've had a number of those come in saying, my chief complaint is maybe I clench, I'm not quite sure, but I wake up with headaches 2-3 times a week. And so if we look and don't see anything very exciting, even as we're analyzing it, we will give them paper tape and say, try this. I've had more than a handful of patients who, when they used the tape, came back and said, my headaches are gone. My headaches are gone. And I'm assuming that that is because they had a mild case of probably upper airway resistance syndrome, enough to release stress hormones during the night, elevate stress throughout the body, and perhaps some clenching and some grinding or protrusion of the mandible. And now that they're well dilated, they don't have that same experience of turning on the autonomic, nervous system sympathetic response. And so that's another thing to know about. And we're going to talk about a whole bunch of those things. It says, can you please reflect on the dental legal implications on dentists getting involved in this level of work? As careful as we may be with our communication and consent, the nature of wellness dentistry is likely to attract patients who could argue are more likely to over-expect the results of our treatment. Well, I guess that depends on what we're saying to them. Basically, I don't pretend to be an expert at anything but dentistry. So if I have a patient come in with type 2 diabetes and on their history and they're on meds, I'll ask them if they've ever heard about the influence of lifestyle on their type 2 diabetes. If they say no, I'll grab this book out of my library that I will hand them and say, here's an expert physician who's written on his work over 20 years, Dr. Joel Furman, and why don't you take that home and read it and tell me what you think? And I've had patients literally reverse their type 2 diabetes by themselves just through reading the book and following the recommendations of the book. So we never want to cross the line in either projecting ourselves as specialists in anything other than oral medicine, nor do we engage in treatments that are over the line. For example, in the United States, a dentist can do a home sleep test, but they're not allowed to diagnose sleep apnea. So I may run a home sleep test, but it would be very much like a CBCT. In the United States, if we scan somebody with a CBCT to look at their TM joints, we're responsible for everything that's on that scan. If there was a tumor on that scan, if there was something else going on that scan and we didn't see it, we're still responsible. So we routinely send it off to a radiologist for their complete analysis and report. The same would be true with sleep apnea candidates, where we would do an overnight home sleep test, then send the raw data to a board-certified sleep physician, ask them for their diagnosis and their recommendations for treatment, and we would follow those guidelines. So I hope that answers that question. Here's another one. How much can we influence disorder breathing in an adult? I see adults who are looking for orthodontic solutions to reverse the effects of disorder breathing. Has the ship already sailed? Charlotte, that's a great question. And the answer varies a little bit, but I would say if we think, in my own mind thinking, if you have an airway obstruction, let's say it's coming from the upper airway or the posterior airway, and I think that by me personally, just doing Invisalign to unravel, crowded anterior teeth is going to cure their airway problem, then I would say that's unlikely. And in fact, we know that one of the major issues orthodontically, and in a sense you could say orthognathistically, is the fact that we have an anterior-posterior problem, underdevelopment very often of both the maxilla and the mandible. So we call it maxillomandibular retrusion that is causing there to be a lack of proper adequate airway. And so in making these changes, even orthodontically, it's not just a horizontal movement of the dental arch, widening of the dental arch that's going to improve the airway. It also has to be an AP positioning, farther forward, which can be sometimes much more complex and obviously can get into palatal sutures and these sorts of things that we work with our orthodontic specialists. So there are dramatic improvements being seen with the proper orthodontic solutions, and sometimes that's even in combination with orthognathic surgery. So can antihistamines at night help? Yeah, they sure can. And so anything that increase that ability to breathe through the nose can be very helpful indeed if there are problems of congestion that way. So antihistamines, along with mouth taping, along with nasal dilators, that sort of thing, can be helpful. But when we get into these sorts of things, we're not just doing this in our office. We're also working with the ear, nose, and throat specialist and the allergist in many cases. So, we're not taking it so far that we feel like we have all the answers in any way. We work under the guidance of others that we partner with in this. Okay, well, I think our time is up, so I want to respect that and just close. Let's see here. I'm going to have to skip this, and I'll just go right here. You go back right there. Yetta, thank you so much. And Patricia, thank you so much for this opportunity to share with my colleagues in Great Britain. And I'm so excited to come be with you September 29th and 30th next year in London for the BSOS meeting there. And I guess you can go on the BSOS website and see the description of what we're going to be doing. But basically, what we've been talking about for 2 hours, we're going to talk about for 2 days, including a lot of clinical implementation.
Thank you so much, Wick. That was amazing. I hope you all enjoyed that. I certainly did. Thank you, Wick, for spending time with us this afternoon and for introducing us to the integrative dental medicine phenomenon and for showing us how much more we can do and the opportunities we have, and for helping us zoom out from individual teeth and managed healthcare, not least over here, and to look at our patients as whole persons and then be able to care for them more effectively and wholesomely.
Yeah.
Literally from birth to the grave, from encouraging breastfeeding to widen those arches, to getting good breathing as we all mature.
Right.
So my fellow colleagues, I think our tasks just grew. There's a lot more to be done. For now, I would like you to fill in the little questionnaire you get sent to you from Patricia, and then you will get your certificates to say that you've attended these 2 hours of CPD. And I think all I need to do is thank you again, DeWitt and Patricia, for your time and help this afternoon. And I hope you all have a lovely autumn weekend.
Have a great weekend. Thank you. Take care now.
Thank you. Thank you, everyone.
Bye-bye.